Good afternoon, everybody, and thank you for joining. I know your most precious asset is your time, and I'm going to try to make the best use of it. This presentation is all about you. Whether you're a physician, an office manager, staff, running a practice, we created this webinar purely to help you, to address questions that you might have and help you determine how and when to deploy chronic care managed services to your patients. One of the things that we definitely want to happen today is for you to understand the new chronic care code and all of the requirements. On a personal level, whenever I speak with physicians or offices or practices, the most important thing for me is to help physicians keep out of harm's way, to make sure they don't violate any rules and don't get into trouble with CMS or any other regulators. Also want to figure out how to help them increase their revenue and give the physician more time with their patient. And I'm hoping that today will be no different. I also happen to mention the triple aim, which you see on the first slide, because CMS is very focused on this. The reason they created this code is that they believe that it will support the triple aim, especially improving quality and patient satisfaction and reducing cost. I'm going to start out with being very selfish from the position of, or the perspective of the physician, the office manager, and the staff, and the entire practice. To look at it, why should they do it? What's in it for them? And I think there's just about everything in it for them, and that's what we're going to cover. First, revenue, respect, and recognition. For too long, physicians, especially primary care physicians, have not been paid for services they provide. A lot of work happens in between visits, and finally, CMS is paying you for that work. We can debate whether that payment should be higher. I happen to be one of those that think it should be. I think the American Academy of Family Practice has already said it. But first things first, let's get paid, and then let's work, hopefully next year, to get it increased. You should be recognized and valued for your work. And you should also, if you want to perform chronic care management services, do it before someone else enrolls your patient, which would prohibit you from enrolling your patient. It's also really nice to have a complete picture of your patient. When physicians have up-to-date, accurate information, they're able to make better decisions that improves the quality of care that they deliver and improves the quality of life of their patients. You can't have that picture if you don't know what other doctors are doing, you don't know about other visits, labs, tests, medications, anything else that happened between visits. One of the things that people are starting to realize is that by having a complete picture of the patient and making it available, you can enlist the aid of the family, friends, and caregivers to help make sure that your patient is compliant with the treatment plan that you've outlined. It does another thing. It allows your patient to value your work. I don't think they've seen it in the past, and I'd like to make sure that through the chronic care management services that the patient starts to see all the things that you do in between visits and begins to value them. Another value for your practice is that other physicians who are taking care of your patient have the same access to that information, so they make better decisions, avoid duplicate tests, avoid prescribing medications that are contraindicated. That, of course, improves the quality of care for your patient and also makes your job easier in taking care of that patient. We all speak about medication reconciliation and how important it is. Very hard to do that if you don't know the medications that are being prescribed by other physicians. It's even harder if you don't even know that those other physicians are taking care of your patient. Chronic care management services can be used to resolve that and to address treatment adherence. It's not enough to have the reconciliation. How well is your patient following the medication or other treatment? If they're not, why? If you know these things, you can address them in between the visits and help make sure that your patient is more compliant, which means better outcomes, a happier patient, and a better life for the physician and the practice. Later on in the presentation, we're going to talk about meaningful use and HEDIS compliance. But for now, let's just say that a lot of good solutions for chronic care management also address some requirements for meaningful use and HEDIS, which would take pressure off of the practice. It's sort of a side benefit. It doesn't cost any more. It's just something that happens. Obviously, there has to be something in it for the patients and the family. And first and foremost is patient-centric care. CMS specifically said that this has to produce a comprehensive patient-centric care plan. That means that the patient has access to the care plan. They have to understand it, which means in language that they can use. And we know that once they have that, they become more engaged and more compliant, which means better outcomes. We know that they're going to result in decreased admissions because of access to the care plan and to the care coordinators. It's going to allow them to participate more, which means better self-management. It also means that when it's appropriate, care coordination can be delivered at home. Now, I know from talking with thousands of physicians that the very best physicians see their patients in the office often, 4, 5, 6 times a year, sometimes more if they're chronically ill or if they're having a tough time with a particular illness. We're not looking to replace that. We're just saying that when the care, the information, the service can be delivered at home, it's nice to allow the patient to receive it without having to make travel arrangements. I've already said that we really want the patient to participate in the care, and the only way they can do that is by having access to the treatment plan, understanding it, and maybe even allowing their family members to see it so they can help be good coaches and advocates. We know that patients love having all the information in one secure place, and we know that this helps improve outcomes and patient satisfaction. And lastly, 24/7 access to healthcare assistance, whether you're providing them, CareSync's providing them, or someone else is providing them, also means better care and more patient satisfaction. Somewhere along the line, you have to talk about the money that this can generate for a practice. But before we do, I want to make it clear that there's a lot more benefit than just money. We've talked about some for the patients and for the practices, and there are some for the family. But there is money. I'm using a figure here of $43 per member per month. It varies by Medicare region. It can be a little lower. It can be higher. If a practice enrolled 100 members in chronic care management services, the yearly or the annual revenue would be $51,600 a year. For 1,000 members, it would be $516,000. It would be unethical and misleading of me to not point out that you would need staff to provide the service. And I was being cute here when I said unless you have people sitting around, because I know that just doesn't exist. And there are some costs to meet the technology requirements. We've heard from many of you that you're already doing a lot of these services, but CMS added some technology and EMR requirements that make it difficult for you to meet the requirements and therefore provide the service in a way in which you can bill for it. We'd like to talk about some of the ways that you can address those technology requirements. But I also want to point out that in our work, and we've been working with patients in this field for several years, long before CMS issued this chronic care management code. And if you had 1,000 members enrolled in chronic care management services, it would likely take you 4 full-time equivalent of 4 nurses or case managers to provide that care. So there is a cost. We know that the revenue exceeds the cost, but I don't want you to leave here thinking that if you had 1,000 members, $516,000 would go to the bottom line profit for the practice. Let's talk about a few facts that probably can be helpful. One, the program began at the beginning of this year. In order to qualify, a patient has to have 2 chronic illnesses. But there's some good news. CMS did not define what those chronic illnesses have to be. They didn't say it has to be congestive heart failure, diabetes, COPD. All they asked is that the physician believe that the illness will continue for 12 months or more, or until the end of life, and that it's severe. Doesn't mean it has to kill the patient, but it does mean that it has to impact the patient, and that without control, without this service, the quality of care and the quality of life will be impacted. We know from CMS that 68% of Medicare recipients have 2 or more chronic illnesses, so it's likely that 2/3 of your patients would qualify. This next point is very, very important, and if you take nothing else away from this talk, please take this. In order to bill this code, you must enroll patients after they're fully informed. That means that they have to have a signed consent to prove it. That consent has to show that you explain the program fully and that you explain that the patient can disenroll at any time. I'm going to repeat that they can disenroll at any time, because CMS covers that point every time they give a webinar, every time they talk. The signed agreement has to acknowledge a copay if it's required, and the consent should be obtained either during or after what they call a comprehensive visit, which would be either an annual wellness visit, an initial preventive physical exam, or a comprehensive E&M visit. And we recently found out that to them, comprehensive is maybe not as severe as you might think, and we can explain that later on if you'd like. There has to be 24/7 patient access to clinical staff. You have to provide 20 minutes or more, non-face-to-face time, and it has to be a clinical person. You can't just have an answering service providing some kind of service, but it doesn't have to be a doctor. I already talked to you about medication reconciliation and monitoring. All I'd like to mention is that a lot of systems today do provide medication reconciliation, although some of them have difficulty when they're trying to reconcile meds from other providers. It's the monitoring part that CMS is especially interested in. And so you need to know that you are providing the monitoring. How well is the patient adhering to your medication or treatment plan? I've mentioned before that CMS expects a comprehensive patient-centered care plan, and that means capturing information from all the providers who treated the patient within the month and then distributing that care plan to them. CMS went out of its way to mention that the care plan has to be made available to all providers electronically, and that faxing does not count. I know that was disappointing to some of you. Please don't shoot the messenger. Coordination with home and health can sometimes be difficult, and what we found is if you do it online, that's probably the easiest way. It not only makes it easiest on your staff, but it also shows that you're meeting the requirement. I've mentioned before that patients and caregivers need access. That's sometimes not so easy. Electronic medical records weren't necessarily built for that. But here's the good news. We also know that when patients and families have access to the information, engagement by the patient and family go up, and compliance go up, and outcomes go up. As I mentioned before, there are some technical requirements, both electronic medical record technical and service requirements. The American Academy of Family Practice wrote a very nice article earlier this year outlining them. You need a certified EMR, and you need an electronic solution that can produce a shareable comprehensive care plan with the providers and the patient. As I mentioned earlier, CMS really believes this will improve quality, patient satisfaction, and reduce the cost of care. Here are some examples of chronic care management activities. These are not the only examples, and you don't have to do everything on this list. I just wanted to give you a feeling for this, and I'm sure right now most of you are shaking your head that you provide most of these, and probably more. So you're already doing what's necessary. Now you have a chance to get paid for it. My only statement is, what a great country. Finally, somebody's going to pay us for the work we do. So who can bill? Well, a physician, ARNPs, physician assistants, clinical nurses, and certified nurse midwives. Therapists and clinical psychologists are not eligible. I want to go over when you cannot bill, because CMS went out of its way to make this very clear, not only in the presentations but in communication. We spoke with them recently, and because some physicians have already mentioned that they're going to try to do this. So this is another good slide to pay attention to. Let me remind you, we're going to make these slides available to you after the presentation. If your patient is in a hospital, a skilled nursing facility, a nursing home, or hospice, you cannot bill for those services because CMS believes, and here I have to agree with them, that the facility is already providing the care coordination and case management services during that inpatient stay. So there's no double dipping. However, if the patient leaves the facility, returns to the community, and between the time that they return to the community and the end of that month, not 30 days, but the end of that calendar month, you provide the services, meet the requirements, and you do it with 20 minutes or more, you could bill. That's okay. The problem is some of you are going to inadvertently try to bill while a patient's been in the hospital the entire month or in the nursing home the entire calendar month. And CMS spots that very easily by their locator codes. So please don't do that. If the transitional care management services is billed that month, you can't bill chronic care management services. You can bill the next month. The good news is that TCM pays a lot more than CCM, so you shouldn't feel put out. The question I always get is, why can't my EMR do this? And it's especially important because people say, well, my EMR vendor told me I could. I think the EMR vendors are saying we meet the EMR requirement for this code. I don't think they're telling you they meet all the requirements. So first and foremost, every electronic medical record or electronic health record with which I'm familiar will allow me usually to put a provider's name, maybe specialty, maybe contact information, but there's no place for me to put their treatment plans and very little chance for me to try to coordinate, summarize those plans. The question is, how do you generate a patient-centric care plan? Because that's the words that CMS uses, a comprehensive patient-centric or patient-centered care plan. You can't, because an electronic medical record was built for providers. It's provider-centric, which is wonderful. Providers need something that's built for them. At the time, when EMRs were being built, nobody thought about patient-centric. So it's going to be very difficult. And how do you make it accessible to the patient and the other providers? Most EMRs have great difficulty unless they're talking to another EMR in the same EMR vendor. And even when you deal with HIEs, patients don't have access to that, and you still have to build a comprehensive care plan. To the right is an example, not the only type, but it's one example of a comprehensive care plan which shows one of the diseases and separates the information. It should have important notes, goals, tasks, appointments, treatment plans, medications, and it should be in using words that a patient can understand. Another wonderful question is, what about the $8 copay? If CMS is reimbursing you $43 and the patient is required to pay a 20% copay, that's $8.60. If they have supplemental insurance or something else, they may not be required. But what about those for whom it is required? What we found is that if you list on a single piece of paper all of the services that the patient is being provided, it really helps. I've listed some of these things here. I'm sure that you could add to this list. I'm also sure that it's pretty easy to explain to the patient that they're getting tremendous value. While CMS is reimbursing $43, a lot of people have gone out and said, including some organizations, that this service is probably worth $75 to $100 a month. Even at $80 a month, the patient is paying 10% for something that they're getting. A patient cannot force you to provide this service. They can't come in and say you have to provide it. So you can say to those that were willing to pay the copay, because you have to collect it. If you don't collect it, CMS will be very disappointed. Trust me on that one. You can just say, look, if you're willing to pay it, I'm willing to provide it. If you're not willing to pay it, I'm sorry, I can't, because this costs me money. It's time from my staff doing all these things, and I have to be paid for it. And if you don't pay, then CMS won't pay, and I can't afford it. And you can continue to see them. Obviously, you're going to take their call when it's in the middle of the night and it's an emergency and it involves, something something urgent? Do they have to go to the hospital? Do you have to get them in the next day? But if it's the care coordination, case management types of things, you can just say, you need to come to the office, and they'll understand. A lot of people are excited about this. They see it as an opportunity not only for new revenue, but to improve the quality of care they can deliver. And they ask, how do we get started? What do we have to do? Obviously, you have to know which patients qualify. You have to onboard the patients. Sometimes you'll hear the term intake. You have to provide the 20 minutes or more. And in the beginning, even CMS will admit that it might take 60 minutes the first month or two. You have to track them. You have to get all those records from all those providers while figuring out who the patient has seen. You have to create that comprehensive patient-centered care plan. You've got to distribute it electronically on a regular basis. You still have to take the calls on evenings and weekends, even when it's not a call that you would normally refer to the physician. It might be on care coordination, case management. You've got to reconcile the meds. And on the right is just one example of something that helps you understand how the patient is doing in terms of adherence and taking their meds. The green shows you if they're taking it on time, the orange if they're taking it late, and the red if they've missed it. And then you can also see how well they're reporting. This kind of tool would allow you to reach out to the patient to find out if there's a particular reason why they're not taking their med. Very often, the reason that they're not taking the med is something that you can solve immediately. Whether it's, I ran out, it's expensive, I can't afford it, I'm worried about a side effect, my neighbor told me not to take it, all the reasons that you hear every day, but you don't know about it until maybe 2 months later when the patient comes in and doesn't need a refill. This is a great question. What if we do not have an EMR? Talk to us, reach out. You have my email at the end of this, and you also have other access points. We've spoken to CMS. You have to meet the EMR requirements, but there are ways to do that without actually having the EMR. I promise you, if you ask us a question like this, it will be someone from my staff or an IT specialist that will call back. It will not be a salesperson. We will respect the fact that you have a legitimate question, and we will answer that question. I hope that you consider us, but we're going to answer that question. Again, meaningful use, why do I care? If you took money, you must meet the meaningful use requirements. They're out there very clear. There are a couple of difficult core requirements for meaningful use. They're difficult to meet. It turns out that, at least in our solution, we address those, so we make it easy for you. So I'm going to just spend a couple more minutes, and then we're going to go to questions. The only reason I'm telling you about CareSync is twofold. First, I'm just very proud of being a member of CareSync, but second, you ought to have a question of who we are and why you should even listen to us. The founders built several electronic medical records in the past, including the first cloud-based or internet-based EMR. We launched patient engagement long before the Institute of Medicine had held its workshop in February of 2013, saying that patient engagement was what we needed to solve our problems. We launched care coordination 4 years before CMS issued the chronic care management code. I can't tell you for sure that it's before they thought of it, because they might have thought of it long before, but before anybody even knew that that code existed, CareSync was providing care coordination to its members. I'm going to try not to read this entire slide. We do have two different offerings. For those practices that do not have the staff to provide the services, we can provide the software, the technology, the support, and the people to provide the service. For those practices that have people already doing case management, care coordination, and just need the technology and software to meet the requirements, we can provide just that. We've been working on onboarding for a long time, so I think we've gotten pretty good at it. I have a little sign on my wall, and I hope that you won't take offense, but it says, when you go to sleep at night, give God your problems. He's going to be up all night anyway. We run a 24/7 system. People are up all night, So why not give us your care coordination problems? We're up all night anyway. Remember to focus on medication monitoring in addition to reconciliation, and remember that it's a comprehensive patient-centered care plan. I don't expect everyone on this call, in fact most people may not know what I'm about to say, but I think I can make it simple. Because CareSync is Drummond certified, which has to do with electronic medical record functionality and other things, when you enroll a patient using our system, that patient will count toward meaningful use. We provide for this view, download, and transmit core measurement number, 7B, that a lot of people have had some anxiety over. And so that's a nice thing. We have Blue Button, which allows you to not only view, download, and transmit, but gives you other options. I don't expect you to understand all of this, but it's good. If you would like more information, you can email us or contact us. Once again, I've made it clear to our CEO that if you do contact us with these kinds of questions, we're going to either have you contacted by an IT person or a clinical person who can explain it to you in simple language. I was the chief medical officer of a large MSO group. We dealt with HEDIS all the time. It seemed like we worked very, very hard to do things that would improve the quality of life of our patients and increase our HEDIS measurements. And it seemed like there were patients who worked very, very hard to make sure that they didn't do the things that would improve their quality of life and would not therefore increase our HEDIS measurements. The new chronic care management service gives you an opportunity to reach out to them and the family and the caregivers, remind them, make appointments, make reminders, do all sorts of things to help them follow your treatment plan, do the things that are necessary to improve their quality of life, the quality of care you deliver, and the HEDIS measurements. So take advantage of it. Doing just those things will count toward the chronic care management services. So CMS is actually going to pay you to do the things that you already do that can help, again, and not only improve the HEDIS measures, but I sincerely believe that as those measures go up, the quality of care and the quality of life go up. So we finished with more than 20 minutes to spare, and I'm going to take questions with one caveat. If I honestly don't know the answer, I will contact CMS and get you the answer. I'm not going to guess. Courtney, to you.
Great. Thanks, Dr. Mihale. We've gotten a few questions come in so far, so let me just start at the beginning and we'll work our way down the list. The first question is, how much confusion do you think there is right now in the marketplace between the CCDA clinical summary document and a patient-centric care plan?
Well, I think there's a fair amount of confusion because the patient-centric care plan, first and foremost, has to be patient-centric. That means it has to be written for a patient. It has to be accessible to the patient. If the patient wants, it has to be accessible to their family and caregivers. And so a lot of times people are looking at CCM and saying, I'm going to produce a comprehensive care plan. What they're producing is a comprehensive care plan from their electronic medical record, and maybe even from some of the specialists to whom they refer, or maybe within their network or their IPA. You have to also include anyone else that the patient is seeing that month. That can be difficult sometimes because you may not already have an outstanding relationship with them or a means of capturing that information. And then you can put together the care plan, and then it has a formal approach. Now, when you said CCDH, I think I was thinking about two different things here, Courtney. So repeat that because I can't see the question.
The question was, how much confusion do you think there is right now in the marketplace between the CCDA clinical summary document and a patient-centric care plan?
Okay, so one has a formal structure. Okay, sorry, I misread that and I apologize. One has a kind of formal structure, and the patient-centric care plan does not have a formal structure. It has guidelines. It has to be patient-centric, etc. So there is no formal structure. There is no one format or one vendor approach. So as long as you meet that requirement, and there's a lot of information on it. CMS has given webinars. You can download those. So I think that's the biggest difference.
The next question is, I'm a pharmacist working with family physicians in a physician practice doing medication management. Would I qualify as a non-physician provider for CCM?
No, it would be very hard for you to qualify as coordinating the care because I think you would be outside the scope of your practice. You certainly are involved in that, and you certainly are involved in medication adherence and medication monitoring and medication reconciliation. But when you think about providing treatment plans and coordinating those treatment plans and evaluating those treatment plans outside of pharmacy, are you qualified to look at those treatment plans, understand if there are contraindications or gaps? So I don't think CMS specifically said pharmacist the last time I looked. They might have, but I have a very strong feeling that that would not be allowed. And Bridget, if you can write that down, because I want to have an exact answer with a citation. I'm kind of obsessive compulsive on this. I like to have the exact slide and citation that CMS used to address that. So I will also make sure we post that. But from everything that I understand, the answer would be no.
The next question is there information online that shows what the reimbursement amount is according to Medicare region?
Yes, there is. I probably should have put a link to it. We will post a link, and I apologize for that. That's a great question, and I'm embarrassed that we didn't have the link in here somewhere. So we will post that link, and Courtney, maybe you can just send a nice, polite email to everybody who signed up, and just, here's the link.
Absolutely. And we actually do have a database that's built into our CareSync.com/CCM site that has all of those too. So you can check it out there as well, but we will include it in the final version of the presentation. Shouldn't a compliant AWV create a care plan for you?
An annual wellness visit typically is creating the care plan from that patient's perspective, the primary care patient, the primary care physician. And even if the doctor does go out to all of the other physicians and providers who are seeing the patient and create it, what does he or she do next month when a new provider sees the patient, a new medication is given, a new diagnosis is identified, a new challenge for the patient in being compliant, a new treatment plan? So it would be nice if everything was static, and at the beginning of the year everybody got together and said, we're not going to change anything. But we know that doesn't happen. During the course of the year, month to month, things change. And that's the whole idea behind it, that as things change, that individual, that physician who's responsible for this chronic care management services, or that clinician, will in fact adjust the care plan to reflect this new information. Again, whether it's a new medication, a new diagnosis, a new treatment plan, a new provider, it doesn't matter. Or even to address the fact that the patient is getting better and maybe we want to alter the treatment plan, or the patient is getting worse, decompensating, and we want to, again, adjust the treatment plan to try to improve the quality of care and the quality of life. So I think the annual wellness visit would count the first month, and then it would be difficult and probably surprising if within the next couple of months there weren't some additions and changes.
So the next question is, of the potential $43, how much does CareSync take for their services?
I'm not the salesperson, and I don't know, and it also varies whether you're asking us to provide all of the services end-to-end, including the people doing it, or whether you're just taking the software. What I can tell you is, if you're just taking the software, you are getting by far and away the lion's share. And my understanding is, if we're providing all the services, after you take away our cost, you're still getting the majority of the money that's left over. You're getting the larger split. But it might look like CareSync's getting more because we're paying to do those services. It's not just we're running a software program. If they email us or contact us, I can have someone who works with the sales team. I apologize, but I'm not the salesperson.
The next question is, can multiple clinical staff fill the 20 minutes per month? For example, 10 minutes of phone calls from a medical assistant and 10 minutes of medication reconciliation from a nurse practitioner.
Absolutely, yes. Great question. I should have gone over this in the presentation, and if you will send in an email that says you're the person that asked it, I'll send you a coupon for Dairy Queen Blizzard, large size, of your choice. The reason that's such a great question is, first, it doesn't have to be 20 minutes contiguous. It can be at any time during the month. Second, it doesn't have to be the same person, but all those people have to be under the jurisdiction.
It looks like we might have lost Dr. Mihale. Just give me a second and we'll see what's going on here with that.
We work whatever EMR you have.
Okay, the next question is, are the chronic conditions from the CMS CCM data warehouse list 27 conditions? I guess that's asking what qualifies as a chronic condition.
Okay, good question. Most of us were afraid that CMS was going to list the conditions, which might inhibit the doctor. And I want to give you an example. So first let me answer the question, then I'll give you an example. There are no lists. There is nothing, no cheat sheet. If you, as the physician, feel that the condition is going to last for 12 months or to the end of life because a patient might be in a debilitated state, and you feel it's severe, that it's going to impact their quality of life, dying is certainly one, but again, I want to repeat that it doesn't have to be dying, because I've seen that they might die from it. It doesn't have to be that, but it might impact. So we use words like morbidity and mortality. Well, morbidity is impacting their quality of life. Then it's you as the physician get to choose. It's one vote. It's the physician's. And it's really, I mean, I'm ecstatic that CMS had the wherewithal and the insight to do that. So let me give you an example. We might not think of osteoarthritis as a chronic condition. We might think of things like congestive heart failure or diabetes or COPD, etc. And you might think, well, that condition is going to go away because the patient is going to go get surgery. Well, someone in my family had osteoarthritis, but they weren't going to get surgery for 18 months because the doctor chose to try several different interventions prior to surgery. And he said, it may be 12 to 18 months until, we're actually at a point where surgery is the only option left. At that point, it would have been reasonable for the primary care physician or the physician taking care of coordinating the care to say, this is a chronic condition. It's not going away for 12 months, and it's certainly impacting the quality of life and the care. So there is no single list. Now, I mean, obviously, if you ask me, does diabetes qualify? Sure. Does congestive heart failure? Sure. I mean, we know what most of those are. But you have some latitude, and your doctor has some latitude. What I would say is if you choose a condition, just say that you believe that it's going to exist for 12 months or more, and that it does have an impact on the patient and their quality of life.
Okay, the next question is, when developing a care plan, what are the consequences of not including a specialist or provider in the patient's network? What qualifies a specialist or other provider as an active participant in the patient's care that needs to be included in the care plan?
Great question. If the patient saw the doctor this month, then the next time that you create a care plan, within reason, obviously if you created the care plan this Friday and they saw the patient this week, you might not have that information. But assuming that then next month you were going to bill for these services, if they saw the doctor and they notified you, whether they notified you directly or through a third party, then you should include them. And it brings up a great point, and so I want to thank you. If we have your email, we'll send you a Dairy Queen large Blizzard coupon. There are many times that a patient sees a physician who's outside their network. They may not have been referred to that physician by their doctor, so their doctor doesn't know in advance. But now, once the doctor knows, then the doctor is required as part of this to include the information from that specialist, from that physician in the care plan, which, by the way, it may not change anything because it may be that the medications and the treatment plan and all the things that go into the care plan are unchanged, but if they have changed, you've got to update it, and then you've got to make it available to that new physician because that's what the patient said, and now we're getting back to patient-centric. Obviously, if you don't know about it, you don't know about it. But you can't just say, well, I don't talk to doctors outside the network, and so therefore I don't know about it. If the patient informed you if CareSync informed you, which is what we would do, then you'd really have to coordinate with that physician. But you now know that they're seeing that physician. When they come in, you might find out, why. Were they unhappy with the specialist to whom you referred them? Was the specialist too far away? And at least now you know what that specialist is prescribing, how they're treating them, which means you now can do a better job of taking care of your patient.
So the next question is, can you enroll a patient without a face-to-face visit?
Okay. This question is probably a little more complicated than you think, so I'm going to take a minute and explain it. There has to be a face-to-face comprehensive visit prior to enrolling the patient. The three examples that CMS has given us, either an annual wellness visit, an initial preventive physical exam, or a comprehensive visit, but they're using the word comprehensive more loosely than some of us might do, meaning that there's a complete review of systems and a complete physical exam. So something substantial, but it doesn't have to be comprehensive per the E&M requirements. That's a piece of information we recently gleaned from CMS. They say anytime within the last 12 months. I would tell you, to be safe, it should be within the beginning of the year. But you can't enroll them unless they do sign the consent. So if you've got a signed consent and you have that face-to-face visit, then you could begin after the date of that signed consent, assuming the consent meets all the requirements. And the CMS did not provide a sample consent. Anyone who tells you, here's the CMS sample consent, no, they didn't. But they did provide the guidelines. And so I would tell you, if you saw a patient in March and now they're coming to the office in April, or you reach out to them and you get the consent, yes, you could begin providing the services. But there has to have been, either at the time or prior, a comprehensive visit. And again, this is only a suggestion from me. It's not per the actual federal register rules. I strongly suggest you try to keep that visit to 2015, even if it's January 2nd.
So the next question is, what if your 24/7 is an extension with a clinic that is checked on a routine basis daily? The voicemail states, call 911 for emergencies, and the EMS service is also employed within the same entity that the clinic is. Does this meet the 24/7 requirements?
If someone's not picking up that phone, in other words, if you say I have a voicemail and then the next day I'm going to return that voicemail, that's not going to meet the intent. I can assure you that. If you said I have a voicemail and someone's going to come in 30 minutes, I'm going to tell you I don't think that meets the intent either, but someone might argue that and I could find out for sure. But the intent is that when they call, they get to a clinical person and they can discuss their care. So 911, obviously you have to do that, but you really want that's another problem for some of the smaller offices. For large offices, it's not, okay? Or maybe not a large office, maybe a large IPA. But for a small office, I think the only way to do that is, and we used to do it, is, this was a while ago, we'd have a nurse carry the beeper and take those calls.
So let's see, we have time for maybe one more question, and then if any of you have left questions on here, we will make sure we get back to each and every one of you with a little FAQ on this, probably within the next day. So if your question didn't get answered on here, we will definitely be in touch with the answer. Last question is, CMS says providers within the group. Does it say other providers? So the EMR shares the patient information 24/7 among all providers on call of the group.
Okay. If the EMR shares the information with all providers in the group, you've met the first criteria, which is great. And then for the specialists or people outside the group, you just have to be able to distribute the care plan. You don't have to have it immediately real-time available, but you have to collect the information from them and share it with them. And I'm going to guess at the rationale now, and the rationale is that you're the one coordinating the care, and you're the people who are taking care of this patient day to day and coordinating care need real-time access. The specialist has last month's information from you, the care plan, the patient-centric care plan, and they have their own EMR. And if they need you real time because something has happened, they can contact you. Again, it has to be electronic, that sharing with those other providers. So that's where some people, have gotten into trouble. They want to either fax those providers things, which CMS came right out and said no, or they want to try and mail it. So the first part is you nailed it. The second part, you just have to find a way of sharing the information electronically. If it's me, I'm going to try and make it available. I'm going to try and make the care plan available. But if I have trouble accepting inbound, what I could do is push it outbound electronically.
To respect everyone's time, which I know everyone is very busy, I think that was going to be our last question. Like I said, we'll make sure we get all of the questions answered, and we will send that out to you, as well as a recording of the presentation today. Thank you all very, very much for attending, and feel free to reach out to Dr. Mihale directly or to CareSync in general at team@caresync.com, and we look forward to talking to you more. Thank you.